thank you for having me. Yes, so I'm very happy for people to stop at any stage, and thank you as well, so that you can ask questions that are relevant for the slides at the time. There are probably too many slides, but a lot of them there for reference purposes for you. And so I'll just start, and this is what we'll probably look at in terms of overview with normal sleep, sleep staging. How much sleep we need, because there's quite a lot of controversy at the moment in the sleep community about that. I've got a slide on what the National Sleep Foundation have just put out, and if you're treating individuals who have any sleep problems, that was likely to make them feel very anxious. So what is sleep? Pretty cool, isn't it? But if we look historically at sleep, sleep was often thought to be the living death, so it's very important to have that statement there that it's reversible and it's a behavioural state of perceptual disengagement. So how much sleep do we actually need? Well, individuals are very firmly fixed on the fact that the more sleep you get, the better you are and the healthier you are. In reality, anybody who's spending more than 8.5 hours and sleeping for at least 8.5 hours or longer is actually a lot less healthy than somebody who sleeps for 6.5 hours. However, once you go under about 5 hours, then we're looking at whether you're looking at partial sleep deprivation because you don't value your sleep, or if you have somebody who has true insomnia and they're sleeping less than 5 hours, that's when we often see cardiovascular problems and another number of other physiological medical conditions. Somebody who's sleeping for or spending 8.5 hours in bed is likely to have depression, because so often you want to sleep away those horrible feelings. You can also have pain-related conditions when people are afraid to move, and then there's cardiovascular disease in terms of strokes and heart attacks and etc. So healthy sleep is actually the bottom of this U-shaped curve, and this is from a large study done in the about 2001-2002, where it found that 7.2 hours was the healthiest length of sleep with very few comorbidities. And interesting enough, when we did a study in New South Wales in 2007, we found that almost 12% of the population were reporting excessive daytime sleepiness, and 18% reported sleeping less than 6.5 hours per night. So if you have excessive daytime sleepiness, this was associated with being older, sleeping less than 6.5 hours, and having at least one symptom of insomnia. But I'll come back to that excessive daytime sleepiness because it's actually quite rare to find it in insomnia. So these are the National Sleep Foundation guidelines in terms of sleep. So here we have the newborn right down to the older adult of 7 to 8 hours, and here young adults and adults of 7 to 9 hours. So it's interesting, it puts a lot of pressure on people. So I also run groups, and I had the extreme in a group last Thursday where I had one girl who said she'd been up all night, she'd been baking, she'd been reading, she'd been doing all sorts of other things. She hadn't had any lie down time at all. Versus the lady who said to me she had the most atrocious night's sleep. She had 6 hours of sleep, but she'd spent 9 hours in bed trying to sleep. So it's different. So catastrophic accidents usually occur because there are individuals who are shift workers. So about 20% of our workforce now are shift workers. The average shift worker does not become nocturnal. They stay on a diurnal pattern where they are sleepy when they're at work, or battling to stay awake, and they're getting poor quality sleep during the daytime from a number of other different factors. And so all of these are very important. If you were to become a nocturnal person, it's thought that it takes 70 days and 70 nights for you to shift over from a diurnal pattern to a nocturnal pattern. And the average shift worker is not going to do it. The average person is not going to do it. So it's always this continual battle. So if we look at daily total sleep time in animals, it's quite surprising. Giraffe gets 1.9 hours in 24. So if we look at the different animals, it's usually based on safety factors. So the giraffe has a long neck, and the valves in its neck are pushing the blood up to its head. If its head is lower than its body for more than 3 hours, it gets an overperfusion of the brain and dies. Also, if it's down on the ground for any length of time, as if an elephant is down too during REM sleep, then they become very susceptible and vulnerable to other predators. Whereas the horse, the sheep and the cow, they are the prey, so it's probably why they have short sleep. They've always got to be on their guard. And the dolphin is hemispheric. The right hemisphere is awake, the left is asleep, the left is awake, the right's asleep. They're both awake, but it's never both asleep for those two hemispheres, or it would drown. So safety factors are very important in the length of sleep that we actually achieve. So what gives us waking time and sleeping time? Well, there are two processes involved. From the time you get up until you go to bed at night, you build up a sleep debt. And we generally need about 8 hours from the end of a sleep to the beginning of another sleep in order for us to sleep effectively. You go to sleep and that sleep debt here is extinguished and the pattern continues. Underpinning this is circadian rhythm. So at certain times of the 24-hour clock, you're going to be more awake or you're going to be more sleepy. And as the sleep debt drops off, circadian rhythm often keeps you asleep a little bit longer, whereas once upon a time we thought that those two processes were independent. Now, if you have a huge sleep debt, it would be nice to think that you could have twice as much sleep, but you can't. Any ideas? If you think about the effects of jet lag, circadian rhythm will usually override sleep debt, but at some point sleep debt will override circadian rhythm. But initially, circadian rhythm is often stronger. But what is interesting is that the quality of your deep sleep following sleep deprivation is better. So you get what we call increased slow wave activity within slow wave sleep. So you're less likely to be woken from environmental noise. And what we are looking at now is whether you have individuals have more spindles in their stage 2 N2 sleep. Is that increased if you're following sleep deprivation? So human sleep and safety. This is something I probably wouldn't be able to prove, but maybe all the different sleeping patterns that we have across the age groups was something to do with when we were in caves. So we have, at night time, we have the young adolescents who can stay up and keep the fires going. We have the hunters and gatherers who are the young adults, and they probably sleep in the middle part, but they're getting up early, or even earlier than that would be the older people and the children, or the young children. So maybe that was a way in terms of sleep and safety that we were able to continue on from just being cave individuals. So this is young healthy sleep. So down here on the y-axis we have stages of sleep and percentage of those stages, and on the x-axis we have hours of sleep. So there's three main myths that are associated with sleep. One is that if you're a really good sleeper, you don't wake. It's quite incorrect. We all wake at least 2 to 3 times a night, and as we age, we will wake more frequently, and by the time we get into our 70s, we will wake anything from 7 to 9 times a night, which is normal. So first point is waking is normal. It's what we learn to do with the wake and how we learn to put ourselves back to sleep when we have any sleeping difficulties. We don't start the night in light sleep and finish the night in deep sleep. We actually cycle through all the stages of sleep every 90 minutes, and the range is between 70 and 100, and I'll go through that with you. And the third one is that many people believe that dream sleep or REM sleep is deep sleep. It's almost the same as being awake. So we cycle round here. So black is awake and green is asleep. And when you're young and healthy, you will only spend 5% of the night in transitional sleep. Some people will recognise it and some people won't. And then we go on to the onset of what we call true sleep, the green boxes, into stage 2. And we spend 45 to 55% of the night in that stage of sleep. We can move, we can easily be woken, we can even talk sometimes in stage 2 sleep. And stage 2 sleep is light sleep. So we spend most of the night in light sleep. So one of the comments I have said to me very frequently is, I am a light sleeper, and of which I reply, we all are. But the difference between somebody who's just a usual light sleeper, which is the usual staging of sleep, and someone who perceives themselves to be a very light sleeper, is that often individuals with insomnia spend a lot of time scanning themselves for a reason or a rationale for their wakefulness or their environment. So when you've been asleep about 25 to 35 minutes, you'll go into slow wave sleep, deep sleep or delta sleep. And that's when you get very few EEG signals getting across the cortex and almost nothing gets to the prefrontal and the frontal cortex, which ensures that the executive planning part of your brain has a rest. During slow wave sleep, children will secrete a huge amount of growth hormone and adults will secrete a smaller amount of growth hormone to repair damaged cells. Children will walk, talk and have night terrors in slow wave sleep. So it's very important not to wake them and soothe them. It's better just to talk to them and maybe guide them back to bed, because if you wake them, you will increase their terror. And there will still be some adults who will have arousals of slow wave sleep, and it's thought probably to be a bit higher than what we used to think of, about 1%. So there's a family or familial predisposition, and we can also have such things as night eating syndrome, where somebody can get up and pour oil into the sugar bowl and eat the lot and have no recollection of it the next day, because this is having a rest. Up here and have a little bit of stage 2 sleep, N2 sleep, and then right up here and having rapid eye movement sleep. So rapid eye movement sleep, there are little twitches, rolling eye movements, but the body is semi-paralysed, so you don't get up and act out your dreams unless you have REM behaviour disorder. Very important. So REM sleep, active brain, inactive body, slow wave sleep, deep sleep, delta sleep, inactive brain, busy body. Now if you get 2 cycles of sleep, about 180 minutes, 3 hours of sleep, you're going to get most of the deep sleep that you have for the night. So most of our deep sleep is in the first 1/3 of the night, but occasionally you will get another bout of slow wave sleep towards morning, but it's not very common. It's also very common to wake at the end of the second sleep cycle, after that longer first REM period, and if you wake then you're going to wake wired. And that's when many people will wake between 2 and 3 and they say, that's it, it's like the lights have been switched on, I can't go back to sleep. So reassuring somebody and talking about how active in terms of brain function is dream sleep, even if they don't remember it, may help you to help them in terms of retraining. So these are the squiggly lines that we have to learn about if you work in a sleep lab. So this is awake, the black boxes. Yellow is transitional sleep. Stage 2, N2 is made up of these things called spindles and K complexes, and K complexes are thought to be the beginning of slow wave sleep. So here you have high amplitude waves, low voltage. REM sleep is high voltage, low amplitude, and if you pick that up there, you could probably put it here between awake and stage 1. Any questions? Am I repeating stuff you know? Is it okay to do it like this? Because I don't want you sitting there thinking, ho hum. Okay.
What's the difference between the stage 3 and stage 4?
Okay. There is no difference now. We used to have stage 3 and stage 4, but about 2 years ago the American Academy of Sleep Medicine put them together because there was a lot of controversy about how stages 3 and 4 were scored in different countries and in different labs. So here if we look at stage 2, it doesn't really shift a lot across the lifespan. Whereas slow wave sleep, here if we're looking at from 5 years of age to 85, it is shut down remarkably. And if you think about during slow wave sleep, you're secreting growth hormone. If you're not secreting as much growth hormone, you're not going to be counteracting the effects of age. And then you look at your skin one day and you think, how did that happen? REM sleep, very high levels of REM sleep from about 26 weeks onwards in utero, and then babies have what we call just active sleep and quiet sleep. And so what we have going at the moment is a program for mothers in the 3rd trimester and teaching about sleep in themselves and also in their babies, and hoping to give them a better understanding of management of sleep, because it is very difficult. And hopefully by doing that we can reduce some of the secondary effects of very disruptive sleep, which may be, the trigger may be in terms of postnatal or perinatal depression. And this is healthy sleep in a 75-year-old, and you look at that and you think, oh no. But it is. So all those wakes are normal. There's a lot more transitional sleep, which means you feel as though you're not asleep as much and you're going in and out of sleep, so that's fair enough. Stage 2, N2 sleep, probably much the same, but a lot more fragmentation of it, and obviously a lot less slow wave sleep or deep sleep. So sleep and plasticity. Why do we sleep? Well, all these points listed here. But I use this diagram of basically a 1960s version of the brain because we had very specific ideas that this was only what happened in those areas, and if you damaged those areas there was no way of coming back from it, and neurons weren't able to replace themselves, and you only had a set number of neurons, and once you wiped those out you were basically gone. But this whole plasticity is quite important, and I like to talk about that with individuals because if you can learn how not to sleep, your brain's pretty plastic, but if you can learn how not to sleep, you can also learn how or relearn sleep. And so that becomes an important teaching point as well. We spend some time looking at the brainstem, the midbrain and the cortex, but particularly talking about the role of the amygdala. So the amygdala takes in a lot of information from the environment all the time. And this is a functional MRI study showing the amygdala firing at night. And yet we know that a lot of EEG signals get stuck or are kept in the thalamus, our relay station. And so few EEG signals get through the cortex and very few get to the prefrontal cortex. So the way you think in the middle of the night is skewed more to an emotional response than an objective response. And so I often talk about if you had a fear of spiders and you were stuck in a room at work, you would look at the spider and slowly edge your way out and get somebody to sort the spider out. But in the middle of the night, if you woke, you would be absolutely convinced that spider was going to leap on you, and it was growing with every breath you took, and you would know that you would not be able to move. And so that's some of our responses. So I'll leave you to read Lunig because he does a beautiful description of what it's like to wake at 3 a.m. in the morning and how you think at night compared to how things are in the morning. So that issue of being swallowed by the great whale of doom. Then at 8 o'clock, like a prayer, the cup of tea rises to your lips, a bird sings, and the whale of doom is now a sardine on toast. He's good. So I'll just talk briefly about light and dark cycles because I think it's a useful thing to get your head around. So a French astronomer in the 18th century put a plant in a dark cupboard, and the plant in the dark cupboard did exactly the same as the plant exposed to sunlight. At night time it also dropped its leaves. And so it did this for a number of days until the signals were no longer strong enough for it to do anything with it, and the plant withered and died. We weren't taught that in biology at school. So from this is this whole concept that every living organism has an internal clock mechanism that regulates patterns of behaviour. Yet our clock mechanism, our main clock mechanism in humans, called the suprachiasmatic nucleus, was only formally identified in 1972. It's the size of the nib of a pen. It has highly specialised cells, and we used to think we had one clock mechanism, but now we know we also have peripheral clock mechanisms. But the suprachiasmatic nucleus controls most of it. And I will show you what really happens in this in terms of light and dark. So here we have the retina. It gets a dark message, optic nerve, retina, hypothalamic tract, and here's the SCN. So it sits on top of the hypothalamus, and they've got the thalamus behind, and then it sits on top actually of the optic chiasm. So you've got all these wires basically coming from the occipital lobe from the brain. So it's very sensitive to light and dark messages. So that message then goes to the suprachiasmatic nucleus. It's then relayed down to the basal ganglia. And that's an important point because so often we have anybody with spinal injuries, their sleep-wake patterns or circadian rhythm can often be severely compromised. And then it's relayed back up here to the pineal gland. Oops. And when the pineal gland gets a dark message, it secretes melatonin. Melatonin does two things. One, it has a slight hypnotic effect, not a very big one, but it's actually responsible for a 40% drop in your core body temperature, and that's the main role of melatonin. Okay? Now, we need light in the morning going on exactly the same route, and when that light gets to the pineal gland, it suppresses melatonin and helps to wake you up. So, Our temperature has a very strong circadian rhythm component to it. Temperature is often quite high just before you go to sleep at night, and it's at its lowest point 2 hours before you wake. So another point is that the waking time is far more important than the going to bed time, unless somebody's going to bed far too early. So this lucky person sleeps from 11:15 to 7:15. Wouldn't that be nice? Minimum core body temperature time is 7:15. So I get up early, mine's a lot earlier. So if we want to change the timing of our sleep, then light exposure before or after that minimum core body temperature time is crucial in planning of this. So if you're a shift worker, you want bright light, late afternoon, early part of your shift, so that you can extend your sleep-wake cycle and you can push your minimum core body temperature time forward. That will allow you, hopefully, to get home, to get into bed before your temperature is too high, before it becomes too hard for you to go to sleep or stay asleep for a reasonable length of time. Okay? Now, for the rest of us, we need light exposure on a regular basis after the minimum core body temperature time. The reason behind that is, as humans, we have a sleep-wake cycle of 24 hours and 10 to 20 minutes, although some people can have a very long sleep-wake cycle or tau of 25 hours. So it needs to be reset on a daily basis, and that daily basis is that you need light, because light will push this minimum core body temperature in this direction here, and it will shorten your sleep-wake cycle so it matches up with your environment. Does that make sense? Okay. And if we're looking at internal light, unless you're close to the light and you're exposed to it, there's a huge difference between ambient outside light and the light that we have from inside lights. So ordinary light bulb that we used to have of about 200 lux is very different from 2,000 to 3,000 lux just as it's getting light in the mornings. Otherwise you have to sit in front of a light box if you live in northern countries and you have to deal with a long northern winter.
What's the average TV put out in comparison?
Sorry?
So watching a screen like a TV screen.
Yeah, the TV screen is probably okay, but it depends to the close proximity. But you see, all our electronic devices now have blue light, whereas before it was white light. Blue light's more powerful in terms of shifting. So if you look at students who play interactive games on their computers, they can easily delay sleep onset by up to 50 minutes. So we really need to be encouraging everybody to turn their phones, their iPads, everything off if they're using it in close proximity for a good 1 to 2 hours beforehand, but people don't do it. Some people are just more sensitive to it and others are not as sensitive. But I think it's probably a combination most times of light and interaction. Yep. So typical sleep phase, if you're lucky, 10 till about 6. There are some individuals, and there tends to be a familial predisposition where they have an advanced sleep phase disorder, so they often go to sleep as early as 8 o'clock or earlier. They can have an average okay sleep period, but when they wake in the early hours of the morning, they're quite convinced that they haven't slept and their sleep is very poor, and it's just out of synchronisation with the environment. And then we have delayed sleep phase individuals, 2 o'clock till whatever they can sleep for. So they're permanently jet lagged. And it's very difficult to hold down a job, go to school, go to uni, do any of these things when you can't go to sleep till 2 a.m. and you're sleeping at least till 10, 12, 1, whatever. So I'm not going to spend a lot of time on that, but happy to answer questions. Total sleep deprivation, many individuals with insomnia actually believe they have total sleep deprivation. But if you totally sleep deprive a mouse by putting it on a disc, and then it falls off the disc, swims around, can't get out, it will die in 2 to 3 weeks. It gets thermoregulatory system goes haywire, it has increased heart rate, it has ulcers forming on its paws and its tails, and it will eat and eat and eat and not put on any weight. And that's the one piece of information you never give to teenagers. So what else disrupts sleep? Obviously sleep deprivation, and that's really not enough time in bed. Other things, traffic noise, aircraft noise, neighbours, snoring bed partners, and it's not unusual for some of my insomnia patients to say to me, I just can't stand my partner breathing. And I said, so you don't want them to breathe? So insomnia is distressing, and it's not enough sleep for the person. So it's a difficulty going to sleep, staying asleep, waking too early. It occurs more than 3 times a week, and it needs to be present for at least a month. But our insomnia patients are wired and tired. They're rarely sleepy, and if they're sleepy and you have somebody who has insomnia and they're sleepy, you'll be looking at shift work sleep disorder if they're a shift worker. You might also be looking to see if they have another sleep disorder such as obstructive sleep apnea, restless leg syndrome, and always look for depression if you've got somebody who has insomnia and they are sleepy. And so you can easily give them the Epworth Sleepiness Scale. Any score greater than 8, I'd be looking at other things. But a lot of our patients, they're wired, tired, anxious. They often have obsessive, intrusive thoughts about their sleep and other things. And it's also not unusual to see perfectionist or control issues. They're very careful at controlling every other aspect of their life and can't understand why they can't control their sleep. And so therefore sleep is actually not about control. It may be about controlling some of the boundaries, but it's about letting go and letting sleep happen. If you try hard, you're only going to do the fight or flight response. Another way of looking at it is in terms of learned helplessness. So this is from Seligman in the 1970s. He put a dog in a pen, and a bell was rung. You've got your conditioned response here, and then an electric current came down, and so as soon as the dog heard the bell, he knew that it was going to get the electric current and stayed there. After a period of time, it was freed from that pen, or sometimes they actually used a belt, and the dog could escape, but it didn't. So it had learned that in that situation, it was helpless. And cues are thought to be very important too in terms of addictive behaviours, particularly with cocaine and such substances, and I'll show you a slide later on if we're able to get to that. But individuals will stay in bed in that helpless state, and they're often not prepared to do anything different. So getting them to shift how they think and what they might be able to do is huge. So depression is very, very common in insomnia. A recent study of young women, and it was just looking at a couple of questions, and they were surveyed between 2000 and 2009, that increased risk of new onset depression if they had reported sleeping difficulties often. So, up until 1996, insomnia was just thought to be a symptom of depression, and what was established in 1996 onwards was the fact that sleep difficulties are often a prodromal sign for a repeat bout of depression or the onset of the first bout of depression. So we need to be very aware of these things. A longitudinal study that was done in Sweden, I'm not going to go through it, but they had, it was a community sample of 3,000 residents, no insomnia at baseline, high anxiety, ended up with insomnia at follow-up, and the same sort of things that were happening with depression and this vice versa pattern. But the Hunt report of 2012 is an 11-year prospective study that was able to show very clearly this bidirectional response between depression and insomnia. So nearly 25,000 people in the study. Pretty impressive. And then looking at the odds ratios, and no depression in Hunt 2, by Hunt 3 they did, no insomnia at Hunt 2, untreated they did by Hunt 3. So comorbidity was 18 to 31% at baseline, and the report really was not able to have a clear line between what was happening in patients with anxiety. And this is just showing you one of the diagrams from the actual paper. But for any of us working in this area, we were very pleased to see this, because it's something that we have to work with the time. So how do you manage the depression? What we've learned is we need to manage both of these together, and we need to look at the triggers other than just a bad night, and help individuals to, what are the things that you can actually do, and how accurate is your perception of your mood and of your sleep. And it's also important to help individuals separate what is fatigue and what is sleepiness, because fatigue can be anything. I had somebody the other day who's just a little bit younger than me, and she said to me, I'm so fatigued at the end of the day. And I said, yes, how old are you? We're all working full time, you know. It's all of those things, you know, and you travel, you've got families, you've got all sorts of things. So common personality styles in depression: anxious, worrying, often irritable, social avoidance sometimes. Personal reserve can be there, self-criticism, perfectionism. So you can see how these things roll over one to the other. Sensitivity to rejection and often being very self-focused. So brain and body care. Exercise. If we can get our insomnia patients to exercise more and we can get our depressed patients to exercise more, it can really make them feel so much better, and it can give them control over an aspect of their lives that they haven't. So again, timing of light, setting boundaries, taking small steps, all of these things are very important. And to acknowledge the sleep difficulties. And I tend not to talk about positive and negative things. If you've been overwhelmed by the fact that you can't sleep well and somebody says, oh, you just need to get positive about that. No, it's perhaps better to look at it in terms of, is it helpful for me? Is it useful? If I keep doing what I'm doing, how helpful is it? What do I achieve by doing these sorts of things? And to think of the word damn. You need discipline to make changes. You need to accept the fact that you've had some pretty awful sleep and your mood's been pretty difficult. But you can manage it better than what you were doing, and you can get help. So those things are important. And then just safety issues. And it's, you know, seeing that you've got other colleagues that you can refer patients to. Today in clinic, I was very grateful that I could ring up a psychiatrist to get some help for a patient that I was very concerned about. And so all of those things are important. And I don't believe that cognitive behavioural therapy is the only treatment for everything under the umbrella of psychology. We need medications, but we need to be able to balance things, but medications don't necessarily have to be the first line of treatment. But our patients need to be treated with a whole plethora of interventions. So anxiety is normal. Why? Because in our society, we often we hear statements made, oh, so-and-so is anxious. And I go, well, everybody's anxious. If you're not anxious, you wouldn't get out of bed, you wouldn't do anything. Think about how your life changes when you have a child. You scan the environment all the time. So you are anxious, but that is a safety factor as well. So motivation and safety, and high levels of anxiety can be extremely useful for short periods of time. So we need to really look at anxiety in a different way. But high levels for long term, we can end up having a panic attack, which is pretty awful, and generalised anxiety makes life pretty unpleasant. So we work through some of these things as well. And the what ifs. And a what if may or may not happen. Anger and sleep, maybe just irritable anxiety, so it's important just to be aware of those things. How do we help individuals learn to sit with being uncomfortable? It's not about getting rid of everything all the time, it's about this is where I'm at, this is what's happening, but when I do this, it will ease, it will pass, and I will get better, but I may not get rid of it, and you probably won't. So, the bear is sitting there looking at his toes or her toes. Very simple things, just teaching people to change their body position. Back straight, tummy in, shoulders down, wiggle your toes. All of these things at work, at home, or even sitting on the edge of the bed at night can be extremely useful, and they're simple to do. It gives somebody an option. So use these, just write this down on a piece of paper for your patients. So anxiety, yes, 100% is not good, and if it's at 80%, it's not very good. But how can you learn to recognise your anxious physiological symptoms earlier so that you can do something about it that relieves it before it gets too uncomfortable, where you feel out of control? And there's absolutely no point in trying in this situation. That stick figure is never going to shift that rock, that stone. So there's a paradox that if we try too hard, we get a fight or flight response and you're likely to be awake. So Risk factors: motor vehicle accidents through inattention, medical consequences, absenteeism, increasing alcohol use or the use of other people's medications, and alternative natural medication. Of course, it's much, much better than anything that's prescribed. And it's not unusual to have somebody who spent thousands of dollars on over-the-counter natural medications because they're so much better than anything else. And yet we don't have a lot of research to back up what is actually good. So here's our insomnia patient. He is wired and tired, and he's distressed. About 6% to 20% of our patients have insomnia and obstructive sleep apnea. But if you're a woman and you're slight of build, you are far more likely to be diagnosed with insomnia than you are with obstructive sleep apnea, because we have a preconceived idea that it's mainly men who have a certain neck or abdominal circumference that are going to have obstructive sleep apnea. And often women can snore and stop breathing, but it's never heard. Or they can do this, and they're having an apnea and it's not picked up. So just be very wary of that. It's worth thinking about. And the other ones is if you've got somebody who lives on their own, you really don't have anybody else unless they're on holidays to help them out. So stages of insomnia, I'll quickly go through this. We've got predisposing factors. Something happens in somebody's life to put them over the threshold. If they were to get some help in those early few days, few weeks, they're likely to respond very quickly. However, they don't usually. They sit on the fence. And so they stay in bed. They can stay in bed from 9 to 12 hours attempting sleep and sleeping for 4 to 5 hours. And they then develop sleep anxiety. So if we are able to help individuals, some of the things that we like to address is the fact that in a study that's been repeated many times in many different sleep labs, you can have somebody wired up for a sleep study, and you can have 10 to 15 minutes of EEG recorded stage 2 sleep. You go in and you touch the person on the shoulder and you say, were you awake or were you asleep? And 90% of individuals with insomnia will say they're awake. So they've learned how not to recognise stage 2. And yet we spend 45 to 55% of the night in that stage of sleep. So that's an interesting one. And then this is just to give you a little bit of a background in terms of REM sleep and perception, and particularly they looked at 100 patients with primary insomnia, and they found that the good sleepers overestimated their sleep efficiency compared with the poor sleepers or individuals with primary insomnia. But what was interesting here is that the primary insomnia patients weren't very good at discriminating between REM sleep and nighttime ruminations. So they would make a statement of, I was awake but I was dreaming. So just to remember that rapid eye movement sleep is physiologically similar to an awake state. And Lunig again, this is the average person with insomnia. They're on a burning bed, heading down, out of control, and they don't want to be there. So awake, worry, worry, awake, just being awake can influence many different systems in the body. So we end up with a fight or flight stress response, that feedback loop, and insomnia. But there's a bit of background here to this, because if we look at our stress hormone cortisol, cortisol is aimed to be high in the morning. You're supposed to leap out of bed and be full of vim, vigor and vitality. Across the morning, your cortisol drops, a little bit of a peak at 2 in the afternoon. But if you have insomnia, and these are from half-hourly blood assays, if you have insomnia, you can have raised cortisol from 8 o'clock at night until 2 o'clock in the morning, which makes it pretty difficult to go to sleep. And in a subgroup of this, it was raised from 8 p.m. until 8 a.m. Whereas if you're sleeping well, your cortisol drops and then starts to rise about 2 o'clock in the morning. So the question then is, do you have high levels of cortisol that predispose you to insomnia, or do you have high levels of cortisol as a result of having insomnia? And we can't answer that question at this point. There are some people who are now doing cortisol testing, but unless you actually do it across a 24-hour period, it's quite hard to work out the relevance of it, because it has such a strong circadian rhythm component to it. So treatments, you might need to look at these more carefully because you can put people in contact with either Sleepio, which is an online program, or Shut Eye. And it can be very useful. And if we think about a stepped care model, think about a triangle. If we can shift people in the early stages of having sleep difficulties, we'll probably shift a lot of people. And then we only deal with those people who have more complex problems, and then the other ones, the next tier up, are the ones that go to specialised centres. So it's good to have other things to offer people when you see them. Stage of change model is been used initially for smoking cessation and then used for drug and alcohol addiction. So here, pre-contemplation state, it's not a problem at all. And you could also relate this to having untreated sleep apnea. Snore loudly, disrupt everybody, but not a problem. Fall asleep in an important meeting, have a car accident, or your bed partner says, I'm off or you're off, and they might want to think about doing something about it. But you can see how that works for drug and alcohol addiction. But people can fence it for years. Seeking help, you'd like to think that they're there, but you need to be able to get somebody from there into action to prevent relapse, but to know that relapse is the norm. But it's to put you back into an action stage, not to flip you over into the yellow pie again, where I did that and none of it works. And it's very important to ask people, how many times did you do this? How often did you do this? And I often use the analogy of if you learn to drive a car, an automatic car, and then you start to drive a manual car, doing it once, would you expect to be able to do that properly? It takes a lot of practice. So cognitive behavioural therapy is very effective, and that's part of the American Academy of Sleep Medicine recommendations. But what happens in general practice, and this is the Beach Report of 2010, is encounter details that, and particularly characteristics in terms of sleep. You're likely to see more female patients, Veterans Affairs cards patients, new patients, and non-English speaking, and this is what happens in terms of insomnia. But most consultations are a standard consultation. I need to spend at least 50 to 60 minutes with somebody. Long consultations are really not the norm, and what happens is there's an expectation often from the patient, but also in time factors is prescription of medications. And 94% of patients in the Beach Report in 2010 were prescribed temazepam. Natural treatments increased by 380% over the last 10 years, pretty high. Over-the-counter medications are usually taken for their second or secondary effect, particularly antihistamines. You're taking them for their drowsiness effect, you're not doing it for anything else. And the National Prescribing Site is very clear to say that most medications actually increase your lighter stages of sleep at the expense of your slow wave or deep sleep. And that is not what the person feels. So sleeping medication is not a long-term solution. Another study that was done in the UK found that from being prescribed hypnotic or sedative medication, the person was next assessed 12 years later. So timing and impact of sleep, and that little top cartoon is pretty relevant in hospital sometimes. Rapid withdrawal, insomnia rebound of up to 50%. So the benzodiazepines, particularly temazepam, which is our main prescribing medication in this group, decreases the time to fall asleep, reduces wakenings, increases total sleep time, but gives you more stage 2 N2 sleep at the expense of your slow wave sleep. But your memory is probably compromised in some way because you perceive that you're having a deep drugged sleep. And for some people, they may only get an increase in their total sleep time of about 40 minutes, and yet taking the medication has a huge impact. So the Z drugs, the non-benzodiazepines of zolpidem and zopiclone or Stilnox and Imivane, they do much the same, but tend not to increase stage 2 sleep as much. But if you have somebody who's small of stature or somebody who has a history of parasomnias, it's extremely important that you don't prescribe 10 milligrams. You start off with 5 and see how they are, because it can easily start that whole thing of sleepwalking again. And the media have given Stilnox in Australia a very bad rap. So how effective are these medications? Well, they're all really GABA modulators, and they're important receptors in the central nervous system, and they mediate alpha-1. The anxiolytic component of it is alpha-2 and alpha-3, and the muscle relaxant component is alpha-2 and alpha-5. But you know, people respond very differently to these medications, and it depends a lot on all sorts of things. So the side effects of the benzodiazepines can be excessive sedation, ataxia, some respiratory suppression, cognitive impairment, and amnesia. And the half-life in some people in temazepam is 9 hours. But in others it can be less, as you well know. So the Z drugs, combining them with alcohol is not a good idea. And they're more selective in terms of sleep architecture. And they're thought to have fewer hallucinations, particularly if they're using it 3 to 7 times per week. There's a more recent study that was published at the end of last year that suggests that up to 6 months, and on a smaller group up to 12 months, if somebody's on zolpidem and it's controlled well, it doesn't seem to be a huge effect as long as there's no increasing use and alcohol is maintained. So melatonin, we've got melatonin, prolonged release melatonin, which is Circadian, 2 milligrams. 2 papers that are published on Circadian, but they're for older 55-year-olds who have sleep maintenance insomnia. But I have seen children being prescribed Circadian. I have seen teenagers prescribed Circadian up to 10 milligrams at a time. And there is no objective data on Circadian at the moment that I'm aware of. It's only questionnaire data. So it may not do any harm, but I think we have to be very careful about giving any melatonin to children, but particularly to teenagers in high doses. Low doses maybe, because particularly in delayed sleep phase it can be extremely effective. But naturally, melatonin drops off at the onset of puberty. There must be a reason for it. So if we give high levels of melatonin to adolescents, I don't know what we may be doing, because we know that if you give high levels of melatonin to different animals, you can change their estrous cycles. So down the road, will we find out whether there is some effect in terms of reproduction? I don't know, but it's worth thinking about. Agomelatine or valdoxin, some good stuff coming out from that, because you've got the combined properties of the soporific effect of the melatonin, but also the antidepressant effects as well, and I'll show you a paper on that. Again, this is just to highlight how alcohol attacks the brain, particularly the midbrain. And normal brain of a 43-year-old and the brain of a 43-year-old alcoholic, it's pretty frightening how it shrinks. So agomelatine has been used quite effectively in this paper that from last year, particularly when you know, alcohol-dependent patients, sleep problems are extremely common, and really what you want to do is, they've been shown to have some abnormal melatonin levels of a 90-minute delay. And so it's a very small sample of 9 alcohol-dependent patients, 6 weeks of nightly doses of agomelatine or valdoxin of 25 to 50 milligrams. They just used the Pittsburgh Sleep Quality Index, but they were able to drop their scores from 13, which is relatively high, down to 7.8. Normal is any score 5 or under, so it's quite impressive. But again, questionnaire data, small size and a small follow-up, but still worth thinking about. Cannabis, I've been involved in a study that is going to print, it's been accepted. 38 patients who were inpatients in a cannabis withdrawal program. They were randomised to either lithium 500 milligrams or placebo BD, and they also are allowed to choose 3 nights when they could take nitrazepam. And we looked at actigraphy in terms of sleep bouts, sleep efficiency and sleep fragmentation, and we found that that was improved on the nitrazepam nights, which hopefully you would. Lithium, unfortunately, was not effective, but what was really interesting is that if you had 1 unit increase in sleep efficiency, you were more likely to stay in the program. So addressing the sleep issues in any withdrawal program of anything is obviously quite crucial. So the cues for sleep and drug taking. Here we have our chook, who can go to sleep very easily in front of the computer. But once she gets into bed, she's wide awake because bed is now a place of wakefulness. Learn to be wide awake and wired in bed. So the environmental cues for sleep and drug taking, it's a conditioning. And it's thought to be particularly relevant in terms of cocaine and amphetamine-like psychostimulants, because that cue can lead to chronic relapsing disorder. So as you're probably aware, cocaine binds with dopamine or DAT, and that also makes it a much slower elimination, and therefore it reinforces the drug-taking behaviour. Add in the aspects of sleep deprivation, poor quality sleep, and put somebody back into that drug-taking environment, the craving is increased, the drug-taking is more likely to occur, and the person obviously experiences relief and relapse. So one of the key components discussed in this particular paper is how do we weaken the cues between extinction or we increase the cues in terms of extinguishing behaviour or extinction behaviour and reduce the reflex to the conditioned stimulus. So if we can reduce some of those effects of sleep onset difficulties, that's very important because that's been shown to be a key cue in drug taking. And then if you have somebody who believes they're not sleeping at all, then they desperately want to have something just to get their sleep, and any drug will do at that point as well. Okay.
So does it work for pulling your tummy low, your shoulders, and with your toes at this juncture?
I think so. It's quite a good one to do if people are just feeling, just a little bit anxious. You pull it into yourselves. Get them to work out where do they find anxiety in their bodies. Is it in your shoulders? Is it in your neck? Is it in your chest? And for most people it's chest or tummy or shoulders, and that's quite easy to work at. But when they say it's in my head, it's actually a little bit harder to sort of get them to do things for their head. But you can do other exercises just to give them 20 seconds of doing something differently that shifts their focus a little bit. And sometimes just sending people away with that is a good starting point. There's lots of other things we need to do with people, but it's a good starting point. Thought you might be interested in this paper looking at pain, sleep and addiction and the characterisation of trends in prescribing or co-prescribing. So we all get stuck if somebody says, I can't sleep. We all get stuck if somebody says, I've got pain. And when you've got pain and not sleeping, you think, oh, of course I've got to fix them. Of course I've got to do something. And really this co-prescribing, this paper was showing between 2001 and 2010, this huge increase in this co-prescribing of opioids and sedatives, which was peaking in 2007. And whether it's for chronic pain or acute pain, it's a real problem because then we have to wean people off. And if we aren't able to address some of either the sleep or the pain issues, there's this increasing tolerance and there's this increasing demand, and we just end up with this very vicious cycle which is quite hard to work with, as we well know. And so many people believe there's a switch. They believe that the good sleepers just switch off at night and go to sleep. But what you've learned today is that you can't switch off because you need lots of electrical activity to go to sleep. You need lots of electrical activity to maintain that sleep. And if you were switched off at night, you couldn't sleep and you'd probably die. And if you lived on your own or you'd had a fight with your partner, there would be nobody to switch you back on the next day. So it's not about getting rid of thoughts. It's not about having a blank slate. It's about how you help individuals to put stuff into the background, to not pay attention. And we know that individuals who have sleeping problems have what we call an attentional bias. So you throw a whole lot of photographs up onto a computer screen of good sleepers and poor sleepers, and then you work out from what they write down of what they remembered of those slides that were flashed up fairly fast. And somebody who has insomnia remembers bed, slippers, owl, night, all the sorts of things that are even vaguely associated with their poor sleep or their sleep environment, where somebody who's sleeping well remembers things that are relevant to their life. So it's quite interesting. So it's what we learn to do with things. And this is one of my favourite photos. Just being locked up in the arms of the pages of your book. Slowing down, having time out instead of, oh my God, I've got to go to bed. And I have to get X number of hours sleep. And if I don't, I can't do something tomorrow. And if that happens, what am I going to do? And on we go. So Garfield here has to learn that he can't find somebody else to soothe him. He actually needs to learn to soothe himself. And if you have insomnia, you can hear a tap dripping 2 houses away and a dog barking 5 to 10 houses away, because you continually scan yourself and your environment for a reason for your wakefulness. So, strategies. Managing your sleep by controlling the environment, not you, not your sleep. Time out, keeping the same waking time, early morning light, and reassociating bed with sleep. So bed's no place for a busy brain, and this is a busy brain. A patient sent me this, I think it's great. So if you sleep well, you'll follow one ball and think, oh, I can't be bothered. If you have insomnia, you might be following 4 balls all at once. So we need to link bed with good sleep or better sleep. Feel safe in bed. Important. Important to ask about history, childhood sexual abuse, and the other one you need to ask about relationships and sexual relationships sometimes. And if I say that to some of my colleagues, my male colleagues, they say, I wouldn't do that. And I said, well, why not? You'd be surprised what are some of the causes of, or some of the triggers for poor sleep. I could never work out why one of my patients used to sleep really well during the week and couldn't sleep well on the weekend, which is the opposite of what often happens. And then I finally came to the point that she had a partner or boyfriend who only came for the weekend, and he was physically abusive to her. So it wasn't safe for her to go to sleep. So stimulus control therapy is about, or the quarter-hour rule, because most people go to sleep or go back to sleep in a quarter of an hour. So it's about taking all the things that can stimulate you to keep you awake, keep them away from the bedroom, and this has got to be one of the biggest things to deal with. So it's not that you think, okay, I'm going to do this quarter-hour rule. Delwyn said I had to do it. So I've now been in bed for 12 and a half minutes. In 1.5 minutes, I'm going to have to get up because she said I did. I've done this before, but I know it's not going to work. Well, that's not going to work, is it? So it's about around about quarter of an hour. If you get into bed and have a sense of drifting, see what happens. If you get into bed and you're wired, you need to consider getting yourself out of bed and doing something else for a while, slowing down until you can do something. So you can stand on the cold bathroom floor, you can dig your toes into the carpet, you can go into another room, but what is really useful to do is change your body position. Don't lie down on the sofa and watch television. You're lying down waiting. Pretty important. If you were standing on a street corner in winter time and somebody was supposed to be picking you up and they're always on time and they don't turn up, what would you think? Something's happened to them, so you might worry and be concerned about them. If, on the other hand, the person who's supposed to be picking you up is always late, what might you be thinking? Here we go again. So you might be a bit frustrated and angry. But with either of those scenarios, at some point in time, you're probably going to catastrophise and have them at least being carted off to hospital. But you wouldn't stay on that street corner all night waiting for them. But individuals stay in bed all night waiting, and they're absolutely convinced that they're wide awake all night, but they can't necessarily account for every second of every minute of every hour on the hour, but they are awake all night. So there's some of the misperceptions that we need to work on. And if you have somebody sitting up, it's pretty hard to go to sleep sitting up unless you're in a sleep deprivation study in our lab. Then they can do it. So the paradox is, put the effort into staying awake. So Mary Poppins had the children on the rooftops of London and she said, stay awake. When she brought them back and they didn't want to go to sleep, she said, stay awake, don't close your eyes. Don't lie down upon your bed. Your pillow is not soft and deep. Don't lie down and drift and dream. And the children went to sleep. So when the effort is about staying awake, the little voice in the head that says you can't sleep now says, you don't want to be doing this, this is really awful. So the end result of this is to convince somebody to sit up at the kitchen table all night writing about their sleep to prove that they're awake all night. And I've never had anybody do it, but one of my colleagues in Melbourne did. Said I only did it once. So there you are, the paradox, what to do. Bed restriction, adding up. If you're spending 9 to 10 hours in bed and you're sleeping for 4 to 5, you are much better at staying awake in bed than you are in sleeping. So, get the person to work out how many hours they're usually staying in bed if they haven't kept a sleep diary, and put the time asleep divided by the time in bed times 100/1, and you get a sleep efficiency. Healthy sleep is about 80 to 85% sleep efficiency. And when I calculate sleep efficiency with many people, it's as low as 50 or 60%. How accurate that is, that's how they're feeling at that point in time. So we would never limit anybody to less than 5 hours, and most times I never really take anybody down than less than 6 hours, because we have to be very aware of safety issues for driving and work-related. But once they have a sense that they're sleeping for 5.5 out of those 6 hours or so, you can then slowly increase their time in bed by quarter-hour increments, and taking them down in the opposite way. If you've got somebody who's more of a night owl, you get them to go to bed early. If they're more of a morning person, you get them to get up earlier, or you can do a combination of these things. Get them to choose. Get them to choose whether they want to do stimulus control therapy or bed restriction, or paradoxical intention, a combination of all of those. Traditionally, stimulus control therapy is used for sleep onset insomnia, and bed restriction more for sleep maintenance insomnia, but I'm really in there for people choosing what they would like to do, because it's more likely to work. So that's how you work out your bed restriction regime. So you've got the notes there to work from. This can be quite an interesting thing to do, and it's as boring as boring as boring. And if you're bored, you might as well go to sleep. Imagine how often we sleep in airports. So what did you do before you got into bed? You pulled back the covers. What did you do before that? You walked from the bathroom. What did you do before that? You turned the tap off. What were you doing before that? You were cleaning your teeth. What did you do before that? You put toothpaste on your toothbrush. What were you doing before that? You were washing your hands. What did you do before that? You turned the tap on. What did you do before that? You went to the bathroom. That's boring. But if you start from the beginning of the day and work up, you will skip things and you won't be nearly as bored. But you'll finish it quickly and you'll say, well, that didn't work. So, exacerbation of the busy brain, napping on the sofa before bed, perseverating with physical reasons why you're not sleeping, all of those things. But if you're continually thinking about your sleep, it makes you very vulnerable to how you perceive your sleep and the consequences of not sleeping well. So how many people went to school and did rote learning? Okay. If you're continually saying to your sleep, I can't sleep, my sleep's gone away, I have insomnia, my life is ruined by my sleep, even when you're not thinking about it, it will pop up. And the classic example was talking with my children who are now grown up. Something came up was, well, how long was a mile? I said 1,760 yards. Well, how long's that? And I said 500, 8 feet it is, and then on you go. And they said, well, that's a lot of useless information. I thought, yeah, it is. But I rote learned it, so it pops up. But you can rote learn how you perceive yourself, and that is not helpful. So it's worth thinking about. So caffeine. Most people, by the time I see them, they've given up all their caffeine. It's a shame. They give up socialising, caffeine, different foods, all sorts of things. So they're putting more and more pressure on themselves about their sleep. If they're super sensitive to caffeine, fair enough. But you can have a cup of coffee in the morning. You might even be able to have 2 sometimes. If you're super sensitive, no. But it's working that out for yourself, not this blanket thing, no caffeine, no alcohol, no socialising, no this, no that. Food and sleep, large meal before bed is unhelpful. You know, got a reduction in hydrochloric acid that you're putting out in the gastrointestinal system. it's going to stay there for a long time before it gets broken down. So we know that the old wives' tale of milk has some relevance, okay? But if you don't like milk like I don't, probably not much. So all milks, rice milk, cow's milk, goat's milk, all have tryptophan. Tryptophan's an amino acid. It needs to pass across the blood-brain barrier to start up the pathway of tryptophan, serotonin, and melatonin, sleep. If it binds with a larger carbohydrate molecule, it will pass more easily over that threshold. And so a little bit of carbohydrate a couple of hours before bed can be useful, but that's not that you go and eat half a packet of Tim Tams, like one of my patients did and then accused us of being responsible for her putting on weight. Eating in the middle of the night is the biggest reward system. If you want to stop your child waking in the middle of the night, you stop the night feeds once they've got to a certain age, of generally older than 9 months. If people get up and eat in the middle of the night, big reward. So just be wary of that one. Exercise and sleep. We always used to think that evening exercise elevated your temperature, gave a space between that and going to sleep and sleep onset, that it would help in the drop of the falling core body temperature at night. A study from last year showed that either morning or evening exercise, as long as it wasn't too close to bed, both were beneficial. So if somebody is starting exercise, it's highly likely to improve their sleep. They like to feel better, get some more fitness back, and that's pretty good. But if they do lots of exercise and they increase their exercise for their sleep, it's not likely to have much of an effect. But it is still setting a boundary, and morning exercise, particularly at this time of the year, plus morning light, is very useful. So medications, main effect and side effect, do think about that as well. Nothing works in one part of the body only. And then review what you want your patients to do. Get up at the same time during the working week. A little bit of flexibility in the weekend, but to remember that going to bed doesn't guarantee sleep onset. Morning light, after that minimum core body temperature. And now I'll do a little section on thinking, and you all still okay? Any questions? Okay. So, insomnia strikes, my brain is circling in on itself, cannibalizing the trivialities of the day and exaggerating the ticking of the clock, reminding me that every minute spent awake is another minute closer to when I have to get up.
Why does Alan Jones, if you listen to him on the radio late at night, make you go to sleep?
Do you really want me to answer that question?
Worked very well for my mother-in-law myself. Just wondering how it fits in here.
Is it because you don't want to listen to him?
No, I just found listening to the radio very peaceful, non-threatening, right sort of program, very effective sleep.
And what do you think's happening?
Establishing normality around you, distracting you.
Yeah, it's distracting and it's pleasant. Yeah. So again, if we get irritable and angry in bed, which many people can, it's how you manage it, and it's just living with some of those feelings. Mindfulness can be extremely useful in any parts of our practice, because it's helping individuals just to deal with the here and now and not doing the what ifs, the future stuff, or tying themselves up in knots about what may or may not have happened in the past. This can be quite useful in terms of a distraction. Just think of a balloon and just watch it. So you can change the background, you can change the timing, you can change the time of year, different seasons, and it's just going with the flow of watching it. If it annoys you, don't do it. But if it's something that's pleasant, see what happens. You could be a tree. You can be a tree anywhere you like to. You can be in the country, you can be in a park, you can be hopefully not a huge tree in your back garden in this last couple of weeks. But you can use your senses. If I was a tree, what do I see? What do I hear? What do I feel? What do I smell? What do I touch? Only thing you probably wouldn't use is taste. So it's just pulling yourself back into the here and now of what you can actually do, and your feet can be the roots. It's that whole issue of being grounded. So the sleep stories that we think about, they're very important, and they're often not accurate. So we often think about our left side of our brain as logical and the right side as the creative part of our brain. But in terms of our brain overall, it can either be our friend or our foe. And my brain keeps me awake, or it's the end of the day. I can just be here and see what happens. I can let go of the day. And they're really quite interesting training things. So this particular slide's taken off the children's website for UNESCO. And it doesn't matter what colour your hair is or what colour your skin is, it's the way you think about things. So this little person with the orangey coloured face and the purpley blue hair is pretty excited about this flying saucer. Well, this person's not quite so sure about rain. So I tell the story is that years ago taking another child on holiday, and it was raining, and this was one of my kids when they're at high school, and she said, I know everybody's really upset about the rain, she said, but I love the rain. I can never ever be upset about the rain. And she came from a farm in northern New South Wales, and it rained every 6 to 7 years. So that shut us all up. So previous experiences influence our perceptions, but again, just keep working on this whole idea of plasticity. It's not set in concrete that that's how it has to be forever. We can and we do relearn stuff, and it does take time. But how we get our heads around things is really important. This is an interesting study that was published last year. They randomised 188 people with chronic insomnia to either a cognitive behavioural therapy group, a behavioural therapy group, or a cognitive therapy group. And they assessed what they called the responders at the end of an 8-week period, and then they assessed them again at 6 months. So in the cognitive behavioural therapy group, both at the end of the program and 6 months, they had about a 72% responder rate. The behavioural therapy was much the same at the end of the intervention, but at 6 months they'd dropped off. The cognitive therapy group, however, didn't do so well in the beginning, but they almost caught up by 6 months. So it really emphasises the importance that we need to get our heads around something. We need to have an understanding of what is needed to do, along with what we actually do in terms of behavioural interventions. So, cognitive behavioural therapy is very much about A, B, C, D. So A is the automatic thought, B is the belief, C is the consequences, and D is the disputation that goes on in relation to the thoughts. But I like to use the word safe, because bed needs to be safe if you want to sleep well. So S is the situation of little or no sleep. A is the automatic thought, my sleep's so bad I can't even meet my friends tomorrow. F are the feelings, I feel awful, I feel out of control. And E is what you do with it. You want to put the onus back onto the other person. If they have one good night in X number of nights, that's a lovely exception. It means they are capable of this. And then what can you do with them to explore and experiment with different ways of managing this and doing things differently? So you can go through a situation, eating breakfast in the morning. What's the thought? What's the feeling? And all of these situations, you can see how the thought fuels the feeling. So often what I'll do is just say, because you don't want to, in a group setting, you don't want to make people feel uncomfortable, I say, well, anything happened today that you're happy to talk about? It doesn't have to be personal. In fact, I encourage people not to have personal things in that. So it could be something like, the traffic was bad. So what's the thought that goes with that, and what's the feeling? And interesting enough, a number of people will keep coming up with thought, but they can't get to the feelings, and that's quite an interesting little thing to do. You can just do it on a piece of paper. Situation, thought, feeling. Just helps them just to look at something in a slightly different way. The shoulds, the oughts, and the trying, how helpful are they? They're not. Lots of pressure on them. And another one is that somebody who's not sleeping well can be the centre of the family and the centre of a relationship, that people's social abilities, their ability to have fun, to do anything, is dependent on whether somebody slept well or they didn't sleep. So I'm very keen to ask individuals, I don't want you to talk about your sleep to your partner, to your family, to anybody. This is what you can slowly do with it, and it helps to take some of the pressure off them, but it also helps to put it into a more normal framework. Don't think of white bears. You do this in Psychology 101. Put a polar bear up and say, I don't want you to think of polar bears. At the end of the lecture, you say, how many people thought of white bears? And everybody puts their hand up. How many times did you think of a white polar bear? Probably a bell-shaped curve. And then you can talk about a study that was done in the early 80s. 2 basketball teams of students, one team wearing a black t-shirt, one team wearing a white t-shirt. You ask people to count the number of times the basketball is passed by the students wearing the black t-shirts. In the middle of all of this, a guy comes in a gorilla suit. Most people don't see him. But once you see the guy in the gorilla suit, you can't not see him. So if you go on YouTube and do, I think it's called the gorilla experiment or something along there, it's quite an interesting little thing. So what we attend to, how we perceive something is very important. So thinking, sleeping, again Lunig, he's excluded from the great important conversation because no ducks are allowed in that house. And many people feel excluded when they're not sleeping well. They feel different from others, and nobody else feels the way they do. And you can't be a great philosopher. Again, talking about helpful self-talk, not negative and positive. So, you can do the alphabet distraction. A is for apple, B is for bear, C is for castle, D is for dog, E is for elephant, F is for frog, G is for giraffe. Well, that didn't work. But if you go A is for apple, what kind of apple? What colour is it? What does it feel like? What does it taste like? What does it smell like? I'm bored with the apple, I want to move on. And you slowly work yourself through the alphabet. It can be useful. You can repeat a word or a phrase. Send somebody away and just say, look, if you've got lots of thoughts in your head, just keep repeating the word the. It's the most boring word in the English language. You have to do it every 3 seconds. You've got to get your tongue up to the roof of your mouth. The. Or let go. No thinking. Slow and steady, but not, if I do this, I'll get sleep. Nope, won't work. Imagine somebody writing in italics, or you can imagine a skywriter. Number strategies. 1, 2, 3. Add 4, rub out 1. Add 5, rub out 2. Add 6, rub out 3. Yep. You can do it with any numbers that you want to do. Or you can imagine being at the top of this huge staircase, an infinite number of steps, and you slowly walk down. And at every landing you can look out and there's a completely different view, or you can sit down, or you can have a rest. Counting strategies, count backwards from 100 or 500 by 3s, and really what you want is you can't be bothered doing it. Count up to 500 or 1,000. Tend not to suggest that very often because people, when they're counting up, speed up. This can get quite complicated, and for that reason it can be quite boring. So you start off with a green triangle, you add a blue square, green triangle, blue square, green triangle, blue square, yellow circle, green triangle, blue square, yellow circle. When you get to a purple hexagon, it's probably not useful. But you can also have barriers of any description, and the barriers can come down between your eyes or behind your eyes from you and the thoughts. So they're protecting you from thinking. Sleep basket, everything in my life will be great when I sleep. No, it won't. You'll still have to commute for 2 hours a day. Perception. Once upon a time there was only the little brown mouse, and now when we think about a mouse we think of the electronic mouse. If we look at those 2 people at the side there, he looks shocking and she looks bright and perky, yet she might be the one with insomnia and he's got some other medical condition. Don't know. So perception, again, is something that we really need to be aware of. Other thoughts in terms of the theoretical perspective is false expectations about sleep, false attributions about causes of insomnia, and how we challenge them, how we increase the faulty beliefs or increase our awareness of faulty beliefs. And it's about making things work for you. So worry is normal. Life is unpredictable, life is stressful. Having a worry time and dealing with stuff that you think might come out, and then being able to say to yourself, look, I've done the best I can with that. I can hold on to it, but all I'm going to do is keep myself awake.
How long does it take you to figure out that somebody's going to have obstacles to any one of your suggestions?
Yes, but.
The moment you hear the words yes, but.
Yes. Yes, but. So if you have somebody who does lots of yes, buts, you know you're going to have a long, slow, hard ride. Yes. And then that's sort of just being able to challenge them enough sometimes to just change their perspective a little bit. Whereas you can have somebody else who says to me, I'm not that sure that my sleep's that much better, but I don't think about it as much, and I know they're going to get better and they're going to just let go of it. So, yeah, and the other ones too with our resistant patients, we have to explore sometimes if they give up their insomnia, what else are they giving up? So if they no longer have a sleep difficulty within a relationship or within a work situation or within, because usually a work situation is not, most people are not very sympathetic for that, but say within a family and stuff, yeah, they can often end up giving up a lot. Mm.
Do you encounter people with the so-called chronic fatigue syndrome sent to you for what?
Look, with chronic fatigue syndrome, one of the hardest things is that, especially in the acute phase or even acute onto chronic, is how they sleep day and night. And so setting boundaries for their sleep is very difficult. The chronic fatigue syndrome with the fibromyalgia patients, they're also difficult. And sometimes just getting them to do very gentle exercises such as being able to do lunges has been shown that can help to regulate some of their sleep and improve some of those physiological responses. It's hard work though. Mm.
I think particularly of the chronic fatigue syndrome where it becomes a disputation whether or not their illness is real. You take it away from them, they feel that their illness is being doubted.
Yes, and none of us like to be doubted. None of us like to sort of have anybody of any description suggesting that what we're experiencing isn't real. And so I guess one of my approaches is that, okay, so what can you do with this anyway? Because this is what you've been dealt. This is not how you'd like it to be. And so one of the things is an approach of dealing with the gap between how they'd like it to be and how it is. So what can we do, both of us, working to at least make a bridge over that gap for them? And some people will respond to that and others just can't for a long time. So sometimes you have to say, perhaps you come back when you're feeling better and you've got a little bit more energy and maybe we can work on those things then. But you've got to have somebody who's in a position to at least start to work with you. Mm. Any other questions along those lines? Yes.
You talked about people feeling safe. If someone's experiencing post-traumatic stress disorder, having very poor sleep tends to actually make a lot of the other symptoms worse. Yet they generally don't feel safe, and they're also quite fearful of flashbacks or nightmares. Is there anything you can do to start addressing that social side?
With post-traumatic stress disorder, you want to be able to give them some choice in how they manage both their flashbacks and their dreams. So sometimes with post-traumatic stress disorder, you can do a thing called imagery rehearsal therapy. So it's easier if they have a theme to their nightmares or their flashbacks. So what you can go with them is write down, if you've got a theme. When you don't have a theme, this is a lot harder. But if they do have a theme to either of those situations, you write it down with them, or you get them to write it down and bring it into you. And then you rewrite with them a scenario that's fairly similar to what they have been experiencing, but it gives them choice with what they can actually do within that. And then you may need to do this a number of times, but then along with that is that you get them to read it out aloud to themselves before they go to bed, at least 3 times before they get into bed. And so there's a subliminal message that often goes with that, and it's been shown to be quite effective. But as I said, the ones that are really difficult to do is when there's no recurring theme. And so sometimes, yeah, it's not easy. Okay.
Is there any connection between, I don't see that you mentioned anything about doing stress management or meditation?
Sorry, stress management and...
Or meditation, that sort of thing?
Oh, look, yes, we do a lot with mindfulness. So we also encourage people to do meditation courses, but not to use meditation to go to sleep. Because if you're doing meditation, whoever's teaching you meditation, they don't want you to go to sleep. So meditation at other times of the day is fantastic, even early evening, but not meditation in the middle of the night, and not meditation as a means of going to sleep, because people will then get caught up with this whole idea, if I do this, I'm going to get sleep. And the same sort of stuff with any of the relaxation exercises. The first thing I do is give them a book on relaxation. And I will maybe go through a couple, and they'll say to them, I want you to go and read this, and out of these, there's lots of different exercises. I'd like you to choose a few that you think you can do. Next time they come back, 9 out of 10 will not have done a thing, and you need to go through it with them. And then after we've sort of worked on a lot of the sleep issues, when they come back, I will do one-on-one mindfulness training with them. And again, sometimes it's working with the anxiety symptoms of the thing. Sometimes if somebody has, their very tight chest, just putting your hand on your chest and feeling the warmth from your fingers through there, it's a way that you can soothe yourself in a public setting and nobody knows. At work you can sit there and just tap your clavicle, because it's actually quite a soothing thing to do. And if somebody says to you, what are you doing? You think, oh, sorry, it's just a bad habit I have of when I'm thinking I do that. You do one side and then the other. So you want to give people little strategies that they can do anywhere, because the anxiety and the depressive thoughts happen anywhere. They don't just happen at home.
Is there any reason, a lot of methadone patients say that they don't sleep well?
They don't, yeah.
Is that the effect of the methadone, or is it when we all, us here would work, a lot of people work with prisoners, so they've got poor emotional control, poor emotional regulation, poor literacy skills, so we can't give them a lot of material to read. They're in jail, and we can't give them safe places to sleep. We can't prescribe medication because they get addicted to it.
Well, look, I've had a few prisoners post, obviously, and some of the environment situations that they've been in. Yeah, it's an ongoing problem for them. I mean, really, what you can do is just do little bits and pieces of this, and give them short strategies, and give them a little bit more of an understanding of what happens to their sleep, of how can they get a little bit more of a sleep debt. Sometimes if you need to, is sitting up in your bunk against the wall for a little bit with your eyes open, putting the effort into staying awake until you feel comfortable enough, or you've made sure that other people have gone to sleep, that it is more safe for you to go to sleep. So, yeah, you can only do what you can do. Mm.
Should we take a moment to look at some of those data about methadone and
Yeah, yep.
sleep?
So these were scribbled together this afternoon as I was feeling guilty I hadn't prepared for this seminar. And here's some old stuff. There are quite a lot of published studies that show poor sleep quality in people on methadone treatment. Some really good studies from Israel there among them. And interestingly, a Spanish study, I don't know how the Spanish say Puig dollars. They used this Nottingham Health Profile scores for men and women at entry into methadone maintenance treatment, and showed again this high prevalence of sleep problems. So right at the beginning of treatment, before they've started. And in fact, there are a lot of studies from early days of methadone treatment that have made clear that insomnia is not only a problem but a persistent problem in methadone treatment. Well, that much we've known for a long time. Some of the factors involved: chronic pain, we spoke about earlier, smoking through various mechanisms, which I've listed there, seem to be associated with worse insomnia, alcohol use. And we postulated quite a number of other factors that might be relevant to poor sleep quality in opioid pharmacotherapy in preparing a study on this subject, which we haven't yet published. I'm going to mention, among other impetus for this study, sleep apnea syndromes. I wonder how many people in the audience are aware of sleep apnea and methadone maintenance treatment. Maybe a little hands up, anybody who's aware of this as being an issue. So we see a dozen hands going up. I remember Nick Lincera saying, and what type of sleep apnea? Is it central or is it obstructive? And what's the answer? Both. Yes, I think that is the correct answer. The early studies suggesting that it was primarily central sleep apnea, which seemed a bit counterintuitive, were followed up by other studies showing that in fact obstructive sleep apnea is at least as common in people on methadone maintenance treatment. And sleep apnea has its serious possible medical consequences, among them excessive daytime sleepiness, which we're calling EDS here, and that was one of the impetuses for this study. We wanted to look at poor sleep and also daytime sleepiness. The literature suggests, however, that sleep apnea syndromes don't typically manifest themselves with an awareness that my sleep is bad. So if the other person isn't there to report on your snoring or your sleep disturbance, you may not be aware of it. There are well-known risk factors for sleep apnea syndromes and therefore potentially for excessive daytime sleepiness, and so obesity for obstructive sleep apnea. Males are more at risk, older people, and of course the use of sedative hypnotic drugs. And the sleep studies that we may or may not send people off for have been done now on a fairly large scale. People methadone treatment, not yet buprenorphine treatment. And so those quite scary studies from Melbourne, I think, was the group of Wang and so on, and they identified there's high rates of central sleep apnea in people on methadone treatment. And central sleep apnea being generally more medically serious, this certainly got a lot of people talking and worrying. In general, central sleep apnea is less common than obstructive sleep apnea, and it usually suggests some sort of serious illness that's impacting on the kind of servo-regulation, like Cheyne-Stokes breathing is that classic example that we learned about in medical school. So subsequent studies of methadone maintenance treatment and of people with chronic pain on opioids for chronic pain have identified obstructive sleep apnea more commonly. And in fact, as this Israeli study, Pelez and colleagues, found obstructive sleep apnea increased during the duration of methadone maintenance treatment there in its prevalence of significant apneas, as they call them, related to increased body mass index. So that seemed to be an explanation. So we, putting these things together, designed a study. This is part of a study done out of Prince Alfred Hospital to look at poor sleep quality using self-reported sleep, and particularly focusing on insomnia in methadone maintenance treatment. And we also wanted to include people on buprenorphine treatment because there's not much information about that, And because there are other grounds and concerns about excessive daytime sleepiness in people on methadone or buprenorphine, we thought we'd better look at that to see how much of a problem it is. It's a risk factor, as Delwyn's pointed out, for industrial accidents, occupational injuries and so on. But of course there are plenty of other drugs, medications involved that could be contributing to that, so we wanted to tease that out. So this study, which I just briefly described, wanted to look at prevalence, severity and contributing factors for insomnia and excessive daytime sleepiness, that's sleep propensity, a tendency to fall asleep in various situations. Looking at men and women, we aim to get large numbers, a good balance of women, and using validated measures of insomnia and daytime sleepiness. We included, at Nick Linceris' suggestion, 2 reference groups, healthy controls. They were people who deemed themselves to be healthy, and also completed the questionnaire for the $20, and opioid users who are not currently on treatment at all. So they were recruited from injecting centres and needle exchanges. So I'm just putting up some of the results here for the Athens Insomnia Scale. That was the validated questionnaire we used for insomnia. And the Epworth Sleepiness Scale, I think that's exactly what it's called, ESS. And the scores there are given on the left-hand side of the table for those different groups. A large number of people on buprenorphine, even more on methadone, 50-50 men and women. Then the people not on pharmacotherapy but using opioids, quite a lot of those from the needle exchanges and so on, and the healthy controls. So the things I bring your attention to, of interest to me, was just how common among the healthy controls the complaint of insomnia was. So you see self-reported insomnia about 40% of normal people. So that's something we need to bear in mind when we ask our patients, do you have problems with sleep, or how common is this among people on methadone treatment? Well, think about how common it is in healthy people, but still clearly more common among people on methadone treatment. So you see the percentage up 70%, about the same for buprenorphine, not much different. And higher again for those people not currently in treatment, so using OxyContin and those sorts of things. We did some statistical tests there. Obviously the healthy controls were a different category, so I didn't test that. And there was a trend towards a significant difference between the treated and untreated people in terms of insomnia. So similar pattern of results for daytime sleepiness. And looking at the figure at the bottom there, you've got a prevalence, that is a score of a total of 11 or more. So it was quite prevalent, and I think it's about the same percentage that Delwyn quoted for normal people in the community, around 12% of people actually scoring on Epworth as having excessive daytime sleepiness. So that's normal, but 3 times that number of people who were untreated but using opioids had daytime sleepiness. Bit of a difference there between methadone and buprenorphine that approached statistical significance. With the test we used, a p-value of 0.002 was considered a trend. So maybe the people on buprenorphine are a little less sleepy in the day, but overall the people untreated but using opioids during the day appeared to be more sleepy. Any thoughts about why that might be the case?
Were you able to tease out the cannabis use in that group, in those groups?
We did include other drug use, including cannabis use, and that will be shown across the page on the multivariable analysis. Cannabis was one of several factors, including alcohol.
Very big component.
Yep, indeed. So looking at those multivariable analyses, this for Athens, so the insomnia scale. Over on the p-value, so whether this is significant in predicting insomnia or not, we see the opioid group not significant. So there was no difference between insomnia rates in people on methadone or buprenorphine. This was already important new information for us. So for people who think, oh, I better go on buprenorphine because I won't sleep very well if I'm on methadone, or I may be too sleepy. We didn't have any evidence to suggest that was the case. Anxiety, however, scored with a respectable odds ratio there as increasing the odds of insomnia, as did depression, and this harkens back to something that Delwyn mentioned, the importance of depression. And of course we weren't able to test the bidirectionality of that, whether depression was causing insomnia or insomnia causing depression, or a mix of both. Cannabis days came in with a significant trend, so the number of days in the month that a person was using cannabis, doubling the odds of current insomnia. Alcohol, benzodiazepine use, other drug use didn't come in as significant. We have a pretty severe test statistically there because we did a lot of statistical tests, and we think that's only a trend that would justify further research in the future. And looking at the daytime sleepiness, again you see the factors that came through as significant on the multivariate analysis. Only one of them really survived, that was depression. Again, a reasonable odds ratio of about 3 times increased odds of daytime sleepiness if you had depression as defined by the HADS score. So with trends there for anxiety, increasing daytime sleepiness, but not actually coming through as significant statistically. And the opioid group, again a trend suggesting that those people on buprenorphine may be less sleepy in the day compared with opioid users using OxyContin and the like. That was the group analysis we did there. Any thoughts about why that might be the case? One of the big questions that came up in the research is insomnia, and perhaps its flip side, daytime sleepiness. Is that actually an opioid effect, or is it a withdrawal effect? So we had some colleagues from Adelaide some years ago who deemed insomnia to be a symptom of methadone not holding a person for 24 hours. They considered what's the most likely explanation of insomnia. They felt this is a sign that the methadone dose isn't high enough. So that's one of the kind of questions that comes all the time through this. The drugs that people are using are causing insomnia, or is the insomnia part of a withdrawal syndrome? So look, I don't know how useful that is. I think it really makes very clear to us that depression can't be left out of the story here. It's the one thing that's coming through reliably, repeatedly, as really, really important in daytime sleepiness and insomnia. So I don't know if that goes some way towards answering your question, Sue. You didn't ask for a Spanish Inquisition, did you?
Asking Richard, was our group self-selecting
Yeah.
for the problems? In other words, the people that are self-medicating. And because there's obviously a very big correlation with alcohol use, all drug use, sedative use, cannabis use, and they've all got sleep problems.
They do. And when we're running studies too, our insomnia patients in studies are usually not as severe in terms of some of our questionnaire data than the individuals that we see through the clinic. So monitoring the environment, as I said before, individuals who are having sleeping difficulties are very good at this because they want a rational explanation for what is actually happening to them. But also, again, an old study, and I'll talk about 2 studies that were done by this group in the 1980s. They had 2 groups that were being studied, and one group was told that they had to give a 3-minute speech after a nap, and they had great difficulty going to sleep. Then they did another study with students, and they had one group going to sleep with marching music and one group going to sleep with relaxing music. And each subgroup, individuals were told that some of them would have to do some neurocognitive testing on a computer the next day, and the ones who would, so they were told that on their way to bed at night. And when they looked at the differences between marching music to go to sleep and relaxing music, there were no differences. But each subgroup who were told they had to do a task the next day on the computer, they took a long time to go to sleep. So that performance anxiety can be huge, but often for the insomniac, they have performance anxiety every night. I must go to sleep. If I don't go to sleep, how can I do that? So it's all this background pressure that is occurring on a repeated time. This is one of my favourite photographs. This polar bear is not frozen stiff. He is evidently napping. So you will be told everywhere that individuals, when they have insomnia, must not nap. But if you can teach them to have a 10-minute nap, you can actually help them to get over their fear of not sleeping. And so a 10-minute nap can be very useful if they stay in N2, stage 2 sleep. But if they nap for longer than about 25 minutes, they have the propensity to go into slow wave sleep, and that will be a real negative factor in terms of their ability to go to sleep or go back to sleep. So short naps can be great, but they need to have an 8-hour gap from the end of the nap until their next expected sleep onset time. And nobody can go in space if they have sleep problems, because you have to put yourself into a body bag each night, tie yourself to the floor, the wall or the ceiling, and evidently where individuals sleep is next to the chemical loo, and it's extremely noisy, so you wouldn't want to be having difficulties with your sleep.
What was the bear doing?
The bear? Sleeping.
It was like up in the air.
A nap.
Yeah. It's actually a World Wildlife card, and it's called Napping Bear. Great photo. So sometimes this is quite a useful thing to do, is to give somebody a scale like this. So what is the scale of the worst thing that could happen to you? And most people will say, I'll be dead. And I say, well, no, it's not the worst thing, because you don't have to worry about it, you're dead. And working through, you know, what is the worst thing that could happen to you? Because we all have secret fears, you know, like 1984, George Orwell's 1984, all have secret fears. But then you say to somebody, well, where would you put your sleep? And where would you put it now? And even if you can get a 10 marks difference, or whatever you want to call it, or a 10% shift, it's a good start. But sometimes what people really come up with is, you know, something happening to their children, or, you know, we have a fear of all sorts of things. So a really close friend of mine died 2 years ago of motor neurone disease. It's a pretty big fear. And so it just helps us sometimes to get things into a slightly different perspective. It's not saying, you know, you should be grateful, because that doesn't work. But sometimes it's just a helpful way of looking at something a little bit differently. So it's about thinking about things in terms of treatment of a jigsaw puzzle. You might get your jigsaw puzzle together and somebody walks along by the table and knocks a bit off, and then you can't find that piece for a while. But it's quite a good analogy, is not to expect to have a complete jigsaw puzzle all the time. That things are going to chop and change. What can you do with it? If you've got a big picture in your head, you know, you can probably work at it pretty well. So what is somebody's goal? If your goal is to sleep through the night and not wake and feel refreshed every morning, it's not going to work. So you need to have realistic goals, and that's useful. And lapse and relapse, you know, we're often pushing ourselves up, falling off, pushing up, falling off, and that's what we often have to do, whether we've got a chronic medical condition, whether we've got insomnia, and very much so if you're, you know, wanting to change your life in terms of alcohol or drug addiction of any description. So again, let the letting go happen, setting boundaries, paying less attention to your sleep. They're all very important things. And bed is my drug, my bed is my dealer, and my alarm clock is the police. So thank you very much for your time. I have a case history we could do, but I'm sure everybody wants to go home.